Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about the GP contract deal for England for 2025-26. Coming up, we'll be looking at what exactly is in the deal and what it means for GP practices in the year ahead. In particular, what it could mean for practice finances and whether changes to the additional roles reimbursement scheme will address the GP jobs crisis. We'll also be looking at what happens now with collective action and the BMA's push for more significant contract reform in the coming years. Hi, Nick. So it's been a really busy week and obviously loads to discuss about the GP contract in England. So let's start with the deal itself. So the BMA has agreed this deal, but this agreement is based on some conditions, isn't it?
Yeah. So overall, it's a deal that brings an uplift of almost £1 billion in funding for general practice. You're going to run through what we know about how that breaks down in a minute, but that's the headline figure, basically. NHS England says it's the biggest increase in investment into general practice in over a decade, a 7.2% increase in funding in cash terms, and it's an estimated 4.8% rise in real terms. And a big point to note is that this increase means that in the financial year ahead, funding for general practice will rise faster than funding for the NHS as a whole. So this is chipping away at, starting to reverse a long-term trend of the share of health spending going to general practice falling every year. That's no longer going to be the case. And as we've discussed before on the podcast, and we'll come on to this in a bit more detail later too, there are some really significant new cost pressures for general practice that kick in from April. So a big part of this funding uplift really just balances out those costs. Although it's worth pointing out here that in previous years, we've often seen costs rise sharply from things like big changes in energy costs or the minimum wage, with very little to balance that out. So this is definitely a big change from many of the contract deals we reported on in the past few years in that sense. But as you touched on, as things stand, this is technically provisional. The BMA's asked the government to commit in writing to negotiating a completely new contract for general practice within the current Parliament. And the agreement on the 2025-26 contract is conditional on that agreement coming through. And just to explain what this means, the BMA and the government negotiate each year on changes to the GP contract. But generally, the changes that are implemented year to year are fairly minimal. They just sort of build on the framework that's already in place. But what we're talking about here is opening talks on a much more substantial overhaul, what the BMA said could be a new contract for a generation, which both the government and the BMA will want to see address big concerns about the future of the profession.
You say that the BMA have agreed this contract conditionally, but this is a big improvement on situations we've seen in recent years, isn't it? I mean, this is the first contract deal for about 4 years that's actually been agreed by the BMA. Every other contract deal before that has basically been imposed on the profession without the BMA's agreement. So let's look at the money for this deal. So as Nick mentioned there, it's almost £1 billion in total. The overall deal includes an £889 million uplift across the GP contract and the network contract directed enhanced service. So that's the contract that governs how practices work together in primary care networks. And then on top of that, there's £80 million for a new advice and guidance enhanced service. So advice and guidance is the system where GPs can get advice from hospitals on how to manage patients in general practice potentially, which might mean that they don't actually need to be referred into hospitals. We knew about both of these sums of money before. The government announced that £889 million just before Christmas, and we've talked about that on the podcast before. And the £80 million for advice and guidance was part of the government's elective care recovery plan, which we've also talked about on the podcast for. Although we didn't know that that advice and guidance money would come to practices through an enhanced service. So altogether, that totals £969 million. There's a little bit more detail on how that funding is broken down. So the BMA says there will be £742 million of that will be going into the global sum. So that's the vast majority of that £889 million is going into core practice funding. The BMA has said it estimates that the global sum will rise to £121.90p per weighted patient. And then the ARS is due to be uplifted by £104 million to cover GPs being added into the scheme for the full year. And we'll come on to talk a bit about the ARS in more detail in a minute, because there's some quite big changes with that. Item of service fees for childhood vaccinations will increase by £2. That's the amount practices get per jab they deliver. That's a total of £18 million overall. Locum reimbursement rates for covering sickness and maternity pay leave will increase by between 15.9% and 17.1%. These payments did increase last year to reflect the 6% pay uplift for GPs, but they've been frozen for many years before that. So these increases are basically to effectively bring these payments in line with where they would have been if they'd been uplifted every year to reflect DDRB pay recommendations. That's a total of £12 million. 32 of the 76 targets in the QOF are going to be scrapped. These are the 32 indicators that were income protected for 2024-25. £198 million from those scrapped indicators will be added into the 9 cardiovascular disease QOF indicators that are already in the QOF. The number of points for those is going to increase. That's in part to help support a government manifesto commitment to cut the number of unavoidable deaths from cardiovascular disease. The remaining £100 million from those scrapped indicators will be used to fund the increases in payments for childhood vaccination and the increase in locum reimbursement rates for sickness and parental leave, with the remaining funds added to the global sum. NHS England has been really clear that that recycling of that QOF money into those two elements of the deal, the vaccination fee increase and the locum reimbursement, is separate from that £889 million overall uplift. So that £100 million which cover those increases and the remainder that's going back into the global sum is on top of that £889 million funding increase. So, Nick, what does all this mean for practice finances, do we think? We know that practices have been really concerned about how the increase to the national minimum wage and employer national insurance contributions is going to affect them from April. What's the view on that now in light of this deal?
Overall, the reaction we've had from GPs is that despite these really big headline figures, this won't amount to a huge windfall for practices, precisely because, as you mentioned, the extra investment is going to be balanced by those increased costs from April. The rise in employer national insurance and the minimum wage that kicks in from April could add as much as £300 million to GP practice costs, according to an estimate quoted in a BMA webinar earlier this year. We've also had some slightly different estimates, like down to £250 million, that kind of thing. But still, it's a substantial chunk. It's a huge part of that money. And the uplift is also then built on this assumption that practices will award staff a pay uplift of 2.8%. That's the amount that's been recommended by the government in its evidence to the Doctors and Dentists Review Body for this year. That 2.8% pay award would consume another big block of the uplift, and that's possibly a similar amount to the national insurance and minimum wage costs, another sort of £300 million potentially. One really important point on staff pay increases, though, is that the NHS England made clear this week that if the Doctors and Dentists Review Body, the DDRB, that's the organisation that advises the government on pay increases for doctors, if that organisation recommends a larger pay increase than the assumed 2.8%, the government could increase the contract uplift again to cover that. So practices potentially won't lose out if the final pay award for staff is higher. They won't be expected just to absorb any extra cost out of that existing uplift. Assuming the government then approves what the DDRB recommends, that would be a big positive. The Doctors Association UK said its view was that most of the uplift would be consumed by rising costs. And essentially that's the reaction I've got from a couple of other GPs. One said this contract would stop the rot, meaning that while in previous years, as you touched on, GP contracts have seen costs rise by substantially more than the funding that comes in, meaning that practices have lost out in real terms by tens of thousands of pounds each year in some cases. So that erosion won't happen this year, and practices might actually see profits increase. The Association of Independent Specialist Medical Accountants was also pretty cautious in its response. It said practices would be relieved that the uplift would cover the cost of national insurance and staff pay increases, but basically that the devil would be in the detail when more in-depth information emerges about precisely how practice funding will change under this contract. And it said too that there would be winners and losers from the contract. And that's a sort of nod to the fact that most of the money from this deal is going to be used to top up GP practices' core funding. What that means is that it's going into practices in the form of an increased payment per weighted patient through the global sum formula, known as the Cahill formula. And the BMA wants more core funding for practices so that they can choose exactly how to spend it, so that they have more purchasing power, for example, to hire more GPs. And this is a big change from previous years where often large proportions of any overall funding uplift that's been awarded to practices went to PCNs, to the Network Directed Enhanced Service, and into the ARRS, for example, rather than increasing funding at practice level. So overall, that's a good thing. It's something that the BMA's wanted. But there's a really big drawback. The Cahill formula is far from perfect, so potentially this uplift will add to funding inequality. The RCGP says practices in deprived areas have around 14% more patients and 7% less funding on average, because the formula just doesn't recognise the impact of deprivation on GP workload in the way that it should. So more money going in through this flawed system potentially means there'll be more inequality to unpick when it comes to a big new contract down the track. So just to touch on some other points, the advice and guidance, Des, is worth just under £13,000 per average GP practice. So that's a welcome bit of new income, albeit for something practices have already been doing, or perhaps something practices in many cases have stopped doing recently as part of collective action. It's worth noting too that the £20 fee per referral may not be enough. In some areas, practices have been paid more than that under local arrangements for taking part in advice and guidance. And there can actually be quite big variation in terms of what's required from practices as part of the referral process through this system. But nonetheless, this is funding for something practices have previously been expected to do across most of the country for nothing. You mentioned the child vaccination fee increase. That could boost income a bit more as well. GPs have pointed out, though, that the fee still hasn't risen in line with inflation because it hasn't changed in previous years. And they've also questioned why this uplift doesn't apply to other vaccinations. It's restricted to child vaccinations. Then when it comes to QOF, although, as you said, indicators that were frozen and income protected in the current financial year are now going to be permanently retired, the fact is that about 2/3 of the income, those frozen indicators, is now going to be added into some targets around CVD, so existing QOF targets, and the thresholds that practices need to hit to earn that money are going to rise, are going to change. So essentially, practices will have to do work this year to earn a block of funding that they were given automatically in the current year. So some of that money is not just being handed to practices without any strings attached. And when it comes to the uplift for locum reimbursement rates, that's also a plus for practices. They won't lose out as much financially when they need to bring in GP cover for an absent member of staff, someone who's missing from their permanent staff due to sickness or leave for some reason. Ultimately, I think the BMA has been clear about how it sees this contract. It calls it a first step on the road to recovery for general practice. It stabilises practice finances, keeps the profession in the conversation with government about these reforms to come. So all in all, it seems like good news for general practice and a step on the road towards improvement down the line.
So let's have a look at some of the actual detail of the deal. I suppose the big change really is around the ARRS, the Additional Roles Reimbursement Scheme. I think the BMA will feel that they've got a really positive shift on this. So I've mentioned the funding increase, but the big change is that there will no longer be a separate pot of money for GP recruitment, and all caps on the types and number of roles that PCNs can recruit will be scrapped, including GPs. So PCNs will now have one pot of money and they can decide how they want to spend it. To be eligible for employment under the scheme, GPs will still have to have qualified within the previous 2 years and not have previously held a substantive post in general practice. But another big change is that the salary that PCNs can claim for GPs plus the on-costs associated with that is going to increase. So the salary that GPs will be able to get via the scheme is going to increase by over £9,000. It will rise from £73,113 to £82,214, and then PCNs will be able to claim that salary plus the associated on-costs. And that's in line with the BMA recommended salary for salary GPs. And we know that the low salary for those GP roles had been a big barrier to networks making use of this funding because it wasn't enough to attract people into the jobs. And so practices were often having to top up the funding if they wanted to recruit a GP via the ARRS. I mean, the other big change from April is that practice nurses will also be added to the ARRS. And to qualify for funding for those roles, the nurses would have to have not had a job within the PCN or any of its member practices within the previous 12 months. An NHS England webinar this week clarified that this doesn't apply if nurses are moving to a promotion or to a specialist role. So if they're moving up to an advanced nurse practitioner post, for example, that's covered by the ARRS. So opening up the funding, in theory, means that networks could decide that they want to shift the balance in terms of who they employ under the scheme towards more GPs, doesn't it, Nick? I mean, you've been speaking to people about these changes to the ARRS. What's their view on this? Will it help address the GP jobs crisis?
This is a really important change, and it's a big win for the BMA, I think it's fair to say. It's not quite what the BMA GP committee wanted, because their preference would have been to see the entirety of ARRS money poured into the core funding for general practice, despite any of the issues around the imperfection of the current funding formula, which we touched on a minute ago. So the GP committee would have much preferred to see this money becoming part of basic funding for GP practices, and they didn't get that. But the fact that this huge block of funding, and to put it in context, total funding for general practice will be something like £13.2 billion in 2025-26, and the ARRS will account for probably 1.6 billion of that. So it's maybe 12% of the entire pot of funding for general practice. And that huge block of cash, which previously most of it hasn't been available to recruit GPs with, now can be used to hire GPs. So that's a big win. But the reaction I've had from LMCs and GPs is that it isn't likely to produce a kind of step change in GP recruitment and retention. It won't end what the BMA has called this toxic paradox of thousands of GPs struggling to find work despite unprecedented pressure on practices. And there are a few reasons for that. Number one is that not all GPs, as you mentioned, are eligible for ARS jobs. It remains the case that only GPs who qualified in the past 2 years and who haven't previously held a substantive post in a GP practice can be recruited to an ARS job. One thing to mention there actually is that if a GP who's recruited within their first 2 years, even if they're recruited within the final week of their first 2 years as a, post CCT, they can then remain in that ARS job for an unlimited amount of time. Anyway, to come back to the original point, for experienced GPs struggling to find work, or even GPs who qualified 3 years ago and are struggling to find work, this isn't going to create jobs for them, or at least not directly. If you spent the whole of next year's ARS funding on hiring GPs, so that full £1.6 billion or whatever it is if it's uplifted further, it could pay for something like 15,000 extra GPs. And that'd be enough to completely change the ratio of patients to GPs in England. There are currently about 2,260 patients for every full-time GP in England, and there's far more in some ICB areas, far more than that in some more local PCN and, individual practices. And that's way above the level often quoted as a safe limit, which is around 1,800 patients per GP. So an extra 15,000 GPs would cut the patients per GP nationally by about a third to something like 1,500. Imagine what that would do for patient safety, access, GP morale. But there aren't 15,000 GPs in their first 2 years post-qualification looking for work, for one thing. So there aren't enough eligible GPs to consume the entire budget, even if PCNs wanted to do that. And at the same time, a lot of the budget is already spoken for. So that's because lots of PCNs have been really successful at recruiting staff through the ARS under the rules that have applied over the past 5 years, when ARS money couldn't be used at all to hire GPs. So they've recruited physios, paramedics, pharmacists, care coordinators and other staff who were eligible at the time. And most of next year's budget will simply cover the salaries of those existing staff. So it'll roll over into paying for staff who've already been hired. So although this is a huge block of money, the impact that it'll have is likely to be fairly limited for those reasons. On the other hand, in areas where PCNs haven't maxed out their allocations, they will have more money available to bring in some extra GPs. Other PCNs might choose to replace existing staff with extra GPs when those other staff move on through retirement or moving on to other jobs. And some LMCs have actually suggested that PCNs could consider making some existing staff recruited through the ARS redundant to bring in more GPs. So that is a possibility, but I think it's unlikely to be a move we see on a big scale. And the one exception potentially could be physician associate roles. We've already heard about redundancies following guidance over the past year that really limits the role that those staff can play in general practice. But where these staff have come into practice teams, again, they may well be integrated by now and valued members of staff. So as people I've spoken to have suggested, this isn't going to bring a massive revolution, a giant influx of new GPs, but it will help create some more GP jobs immediately, especially with the increased pay on offer, which is something that people feel has suppressed numbers of people coming forward for jobs that have been available in the second half of the current financial year. And over the longer term, more of the budget could potentially shift towards being used for GPs. But then there's also a review of the whole scheme planned for the year ahead. So whether there is a long term remains to be seen. And the BMA said that ultimately it wants a practice level solution to recruitment of GPs and not a scheme like the ARS, which operates at a PCN level and where funding is outside of the basic core funding for general practice.
One real concern about the ARRS for this year is also about the rise in employer national insurance costs, isn't it? Do we have any idea about whether PCNs are going to get an increased allocation for their ARS pots of money to cover that?
So that's not entirely clear at this stage. There was a line in a BMA summary document that lists most of the changes for the year ahead. And it said that the GP ARS scheme from this year would be amalgamated with the wider ARS scheme. And then it said alongside requisite additional funding. So you'd think that requisite additional funding would include national insurance costs, but I think it probably is just referring to the fact that GP ARS money was only available for 6 months in the current financial year. So for next year, it's being bumped up to cover 12 months and then, amalgamated with the wider ARRS pot. If the ARRS pot isn't expanded to cover additional costs for employer national insurance, as well as for pay increases and so on, then obviously it'll be stretched thinner and PCN's capacity to bring in any new staff, as well as to retain existing staff, and particularly to bring in any new GPs, will be limited. I think you'd expect it to be uplifted, but there's some form from previous years, albeit under a different government, of total funding for the ARS not being uplifted despite pay thresholds increasing. So practices will very much hope that's not what happens this year.
Yeah, I think that's something we're going to be looking out for in a lot more when there's more detail of the contract comes out in the coming weeks about how that funding is going to be allocated. There are a couple of other things about the contract we should probably mention here before we move on to talk about longer term issues. Nick's mentioned, and I mentioned earlier, the item of service fee for childhood immunisations. So that increase only applies to the childhood jabs, not other jabs like COVID and flu. And NHS England has said that that is in recognition of the fact that the work to do those childhood jabs is more onerous than the other, what they called more straightforward adult vaccinations. I think we've mentioned on the podcast before that the BMA has been pushing for uplifts to all vaccination item of service fees in contract negotiations for a number of years now because they've not been uplifted for a really long time. And the rates that people have been getting up until now don't really reflect the work involved in them. NHS England says it's going to be evaluating whether that £2 increase impacts on uptake of childhood vaccinations during the coming year. Personally, I think it's quite unlikely it will make much of a difference, to be honest, because £2 per jab is not really that much. And as I say, many practices will probably see this more about bringing the payments in line with what they actually should be. And I think, it's notoriously difficult in some practices in some parts of the country to hit those kind of targets for childhood immunisations for all sorts of reasons that are very complex. Access is potentially a really big issue and there's a lot of concern about this. So there'll be a new requirement for practices to keep their online consultation tools open throughout core hours. And our senior reporter, Kimberly Hackett, wrote a story this week highlighting that GPs have basically said this is going to be a nightmare and could put patients at risk. We kind of knew this was coming because it was mentioned in passing in the government announcement of that £889 million before Christmas. And I think at the time, I said on the podcast it would potentially cause problems. NHS England has been quite keen to point out that this is only for routine appointment requests, medication queries and admin queries, and that practices can really stress to patients that they must call the practice if it's urgent and not use the online option. But I think there's a lot of concern that this just won't really work in practice. GPs are worried that urgent things could come in via that system and they could get missed. They're also worried that it's just creating unmanageable work and that they just don't have the staff to deal with the number of requests they're going to get. The reason many practices turn off these systems partway through the day is often because they just have too many requests to get through, and it's a way of making sure they can clear through the work they already have before the end of the day and keep things safe. By all accounts, this was one of the really tricky parts of contract negotiations. That's what NHS England Director of Primary and Community Services, Dr. Amanda Doyle, admitted to a webinar this week. But I think this was probably a non-negotiable from the government. The government really wants everyone to have the same experience of access, whether they walk into the surgery, whether they phone up, or whether they go online. And so having these online consultation tools open during core hours was seen as essential if it was going to deliver on that. There's going to be a new GP patient charter which will set out what patients can expect from their practice, and that's going to detail the way in which patients should be able to contact their practice. And apparently it's going to really specify that online consultation systems shouldn't be used if something's urgent. But I think it's fair to say that a lot of GPs are quite sceptical that that charter is going to address these concerns. Now, this requirement doesn't come into effect until the 1st of October. And between now and then, NHS England and the BMA GP Committee, along with the GP Joint Committee on IT, which also has RCGP representation on it, they're apparently going to be working on safeguards to ensure this system is safe. So potentially there's more to come on that over the next 6 months. Finally, probably worth mentioning is continuity. So there's a change to the capacity and access payments that primary care networks receive from April. One part of that payment will now pay networks to work with their integrated care board to use population health risk stratification tools to basically identify their most vulnerable patients who would most benefit from continuity of care. There are some other technical changes to various bits and pieces of the contract as well, and you can find a full list of all the changes in our roundup article on our website. So we're going to take a quick break now and then come back to talk about collective action and where we're at with that and what happens next, including longer term prospects for significant contract reform. Just a quick message to say that MIMS Learning Live Digital is taking place online across 4 evenings from the 10th to the 13th of March. If you need some help keeping up to date with clinical practice, our colleagues from our sister site MIMS Learning can help with this series of evening webinars. You'll have the chance to earn up to 6 CPD hours from the comfort of your own home or practice with presentations from expert speakers who are passionate about their area of expertise. For more information and to register for your free place today, visit mimslearninglive.com/digital.
Hi, I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, GP Online's sister publication, providing clinical education for primary care teams. I want to let you know about some free learning modules that we have available as part of our latest campaign. For 2025, we're focusing on earlier cancer diagnosis with our Patient Presentation Pathway for Cancer campaign. Now, we know from talking to GPs that the prospect of missing a diagnosis of cancer is a real concern. So this campaign provides learning and empowerment for you around identifying at-risk patients, spotting signs and symptoms of cancer, and making best use of referral pathways to optimise early diagnosis. Our commitment is to create a positive impact, so we're offering these modules, podcasts and webinars for free for the rest of this year, making them as accessible as possible for you. Take a look at mimslearning.co.uk for tips and clinical insights.
So, Nick, the BMA has agreed this deal. Where does that leave us with collective action? The union is saying that collective action is paused, but what does that actually mean for practices on the ground?
This is a really interesting point. I think it really goes to the heart of how the action general practice has taken over the past 6 months or so is completely different from the industrial action we've seen over the past year or so from other parts of the medical profession. When hospital doctors went on strike, an end to industrial action meant those strikes stopped. But in general practice, the actions practices have taken, adopting safe working advice, stopping work they weren't being paid for and so on, none of that was in breach of their contracts. And a lot of it, as we've talked about before on the podcast, is stuff that the BMA has been urging practices to do for years, for at least a decade, before the idea of calling it collective action was ever dreamed up. And as a result, whereas an end to industrial action in hospital meant no more strikes, in general practice, the pause in collective action doesn't mean practices going back to seeing an unsafe number of patients every day. It doesn't mean abandoning the shift to 15-minute appointments. And it doesn't mean practices starting to deliver services they aren't paid for again. What it does mean is that rather than there being a national drive to get as many practices as possible to take these sorts of actions, that's generally what collective action was. It was a national drive to sort of get practices to push harder on doing the kind of things the BMA's always wanted them to do. We now move back to a situation where practices can just think about these decisions locally or individually. I think in most cases, it means practices will simply not go further than they have already. Although I think anyone in the process of moving to 15-minute appointments, say, or moving gradually towards the BMA limit of 25 daily patient contacts per GP isn't going to be expected to stop that.
The BMA has a special LMCs conference scheduled for the 19th of March. We know that they want some kind of commitment from the government on negotiating a new contract by then. What exactly are they asking for, and how likely are they to get this?
The BMA wrote to Wes Streeting this week to reiterate that it had agreed to accept the contract only if the government confirms in writing that it will negotiate a new substantive NHS GP practice contract within this Parliament with the BMA's GP committee. As you said, the deadline for that written commitment to come through is the 19th of March, and that's the date of the special LMCs conference. I mentioned a minute ago that the difference between the action GPs have taken and the kind of industrial action we saw in hospitals last year. The special conference was basically set up to debate whether general practice should escalate towards something much more like what hospital doctors did. So in general practice, that could mean collecting undated contract resignation letters. And we know that that sort of motions around that sort of idea are exactly what's been submitted to the special conference. Potentially things like closing practices for a day at a time, something along those lines, things that are much closer to actual industrial action. But I think the agreement on this contract and the prospect for general practice as a whole of being on good enough terms with the government to start talking about a really major contract change for the future means this conference is really unlikely to press the nuclear button and step up industrial action. I think the government will commit in writing to start talks on a new contract. It seems like such an easy thing to do that it's kind of unimaginable they won't write a letter giving that commitment. How the talks actually go and when they start is maybe another matter, but agreeing to have talks seems so straightforward that you just can't imagine the government not just whipping out that letter within the next few days. In terms of what the BMA wants from that contract, the GP committee has been talking for more than a year now about the idea of a substantive new contract from something like 2028. Rather than the usual tweaks to the existing contract that we see each year, something more like the shift we saw in 2004 to the so-called new GMS contract, which is basically what general practice works under now, with the QOF, the Cahill formula, enhanced services, and that sort of thing. The new deal the BMA wants would change how practices are funded to better match pay to workload rather than what's been referred to as an all-you-can-eat buffet under the current deal, which basically offers a set amount of money per patient for effectively an unlimited amount of work for each of those registered patients. And the BMA said it will also push for a recommended maximum number of registered patients per fully qualified full-time equivalent GP as part of a future contract, and some sort of evidence-based target share of NHS resources that should go to general practice. So the profession would then sort of move to that over time. I think the BMA's actually talked about an incremental uplift of something like a further 1% of the NHS budget going to general practice each year or something like that. That's some of what we might expect in terms of what the BMA wants. And obviously there are going to be demands from the government side too. And based on their current priorities, I think you could imagine there being something in there to tie practices into working in NHS neighbourhood teams. However, those sort of take shape over the coming years, and perhaps we'll find out more about that from the coming 10-year NHS plan. You know, it's quite likely we'd see something around access, but it also could be things like continuity, that kind of thing.
If the government is up for doing a massive wholesale contract overhaul, there's going to be clear priorities of things that they want in there. And I would imagine the things that they'd be pushing for was things that would support this whole shift from hospital to community as well. And potentially, things that would really tie in with the prevention strategy. So you could see more targets around things that are to do with disease prevention as well. So there's things the government want. So maybe, negotiating a wholesale new GP contract is very much in their interest as well as the profession's interest.
You're absolutely right. The three main aims that the government's talked about, analog to digital, hospital to community, and moving towards prevention, those three things you could imagine very much being tied up in the thinking around creating a new GP contract.
Before we finish, what do you think GPs think about the deal as a whole? What have people been saying to you about it?
GPs aren't popping champagne corks, but I think after years of pay erosion, years in which uplifts given to general practice simply didn't match the rises in costs that they faced each year, so their funding was eroded year on year, there's a recognition that this contract, this agreement, brings that era to an end. Costs are rising, but this time there's money coming with those costs. And again, it's not going to end the jobs crisis, but it is a start. There's the hope also of more to come down the line, and the sense that perhaps this is a government general practice and the BMA can work with. This is a platform to build on, and ultimately it's a lot more positive than anything we've had to report on contract-wise for a good few years, I'd say.
Yeah, definitely. People I've spoken to have been broadly positive about it as well. If, as you say, it is a platform on which to build something, some wider changes for the future. Obviously, as we've been talking about, probably needs to be a new contract or significant contract changes that address some of the key problems facing general practice, namely workload and retention of GPs. Although, as I was saying, earlier, the other thing I have heard a lot is a lot of concern about people about that online consultation thing, but we kind of need to see what comes out about that before October. Just for people listening, we've got a really great piece on the website this week, which we'll link to from the notes, and that's from a group of early career GPs talking about what they would like to see from future contract reform, which is really worth reading. I mean, one of those GPs is Dr. Liam Loftus, who was a guest on last week's podcast episode. But I mention that now because they approached us to write that piece because they feel really positive that this is a real moment of opportunity and that there is hope that things could get better. But to deliver that, we'll need a completely new GP contract. But as they say, if that happens, it's a once-in-a-generation opportunity to ensure general practice is really fit for the future for both patients and for GPs. I mean, one other thing they point out, and I think this is something we'll have to be borne in mind over the coming months and years, is that it will be really important to make sure younger GPs and GP registrars feed into any future contract negotiations because, they're the GPs of the future and they're the people that will potentially have to work in that system for the next 2 or 3 decades. But as I say, we'll put a link to that in the notes for this episode. So what happens now, Nick? There could be more money coming after the Doctors and Dentists Review Body makes its recommendations on GP pay, couldn't there?
The immediate next step, as we've said, is getting this confirmation from government that it's prepared to hold talks on a major reform of the GP contract. That's the first thing. And that's what will sort of set this agreement on the contract for next year in stone. Then the special conference, which, as I've said, seems pretty unlikely to produce a revolution of any sort, assuming the contract's been agreed by then. One further factor that's still to come is advice, as you say, from the Doctors and Dentists Review Body. And we touched on that earlier a little bit. The assumption built into the contract package at the moment is a 2.8% increase for staff. So that includes the kind of uplift that you'd expect for salaried GPs. If the DDRB recommends more, which it is probably quite likely to do, NHS England has suggested contract funding could increase again to reflect that. So if funding does increase, then GPs should be fairly happy with that. But it would need the government to agree to that when it sees the DDRB recommendations. That's not a foregone conclusion. Last year, the government did accept DDRB recommendations, which resulted in the ultimate 7.4% uplift to global sum that we saw in 2024-25 for general practice. But this is a bridge that will need to be crossed when it comes. And clearly, in general, government finances are really tight. So is there a chance that the government would say to GPs, you've already had a big uplift, you'll have to cover a bit more than the 2.8% we initially assumed out of what you've been given already? It's not completely unthinkable, or at least maybe they'll meet them halfway. I mean, who knows? I just feel like that's not a foregone conclusion. So basically, we'll have to wait and see. In some recent years, DDRB advice hasn't come until well into the financial year. Last year, for example, its advice was only published after the general election in late July. And obviously the fact that there was a general election would have delayed that to some degree. But ultimately that advice only appeared nearly a third of the way through the financial year. So for that entire period, until the DDRB recommendation arrived, GPs were working with the 1.9% uplift that the previous government had awarded them. So one thing GPs will welcome this year is that the DDRB advice is likely to come a lot earlier because, as with the contract negotiations, which started at the beginning of January, the timescales have moved forward this year. I mean, the government has said that by next year, it wants to have settled the GP contract completely before the financial year begins. And I think that's a change GPs will really welcome, that we'll be moving towards in this financial year.
So anyone listening, you can read all of our coverage on the GP contract on our dedicated page at GPonline.com/contract. Well, that's it for this week. Thanks to Nick, and thanks so much for listening. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news, including more coverage about the GP contract, and access a host of other resources on our website at GPonline.com.